So for our learning objectives for today, we're gathering here to really raise awareness of health issues and experiences of survivors of intimate partner violence and human trafficking, in particular during the COVID-19 pandemic. We're also here to promote collaboration between the different provider types. There are domestic violence service providers joining us here today, medical legal partnership folks joining us. In particular, let me just call out the civil legal services providers, and then community health center staff. Then finally, we're hoping to help you better identify some really practical strategies and tools that those of you at health centers in particular and medical legal partnerships and the DV provider organizations can use and implement to be able to address the needs of survivors and promote prevention. This is very much in line with HRSA's 2017, their Office of Women's Health 2017 directive and set of initiatives where they decided to come up with that 3-year plan to finally address intimate partner violence and human trafficking. I want to introduce our presenters today who will talk more about our learning objectives, right? How you can really collaborate across the board to address intimate partner violence and human trafficking for our patients and clients that we're all serving. Elena Josway is a program director for Futures Without Violence, and she will be presenting alongside Dr. Kimberly Chang, who's a consultant with Futures Without Violence, but you may be familiar with her as well because she also serves in other roles such as family physician with Asian Health Services. She's director of human trafficking and healthcare policy there, and she's also vice speaker of the House on the executive board of directors for NAC, the National Association of Community Health Centers. I thank them for joining us today to really do that deep dive into some content that we hope you all will help us really tease out any questions by sharing your comments and questions in the chat so that we can follow up in the end with a Q&A portion and help everyone return to the field to help folks around the country in need of help. Elena and Kim, I will pass it on to you and let me know how you would like me, when you'd like me to advance slides, and thank you.
Thank you, Bethany. I was on mute. You'd think a year into the pandemic, I would have figured that out. Again, my name's Elena Josway from Futures Without Violence, and Futures staff leads the National Health Network on Intimate Partner Violence and Human Trafficking, like Bethany mentioned. And through the NHN, we're working with community health centers to support those at risk or surviving intimate partner violence and human trafficking and exploitation, and to think about prevention and bolster our efforts around prevention. Some of the topics that the NHN is looking at include increasing staff capacity for what we call healing-centered engagement on this topic of intimate partner violence and human trafficking, assessment and universal education approaches to addressing IPV and human trafficking, which we'll talk a little bit more today, building partnerships between community health centers and their community-based partners, policy and systems change around health, prevention, like I mentioned, promoting health equity and safety outcomes for those who have experienced intimate partner violence and human trafficking. You can learn more about the NHN on the website that's linked on the slide, and or email us as well. Our email is listed. Next slide. So here, we just wanted to take a moment really quick to lift up some resources that Futures and our colleagues have developed around supporting staff. Rest and self-care are so important. It's how we keep going. It's a necessary part of our job. We'd invite you all to explore some of these resources listed on the slides, especially thinking just about where we're at right now in terms of the pandemic and COVID. There's tools from our Workplaces Respond to Domestic and Sexual Violence program, model policies and resources to support staff who may be survivors. There's a link to a program, Capacitator International, that has some really great tools and videos on mindfulness. A workbook, What About You, that includes some self-care and org care checklists that might be also helpful to you and your staff. Next slide.
Okay, this is me. I'm Kimberly Chang. I'm a family physician at Asian Health, and I'm going to bring that perspective into the talk today. And thank you, Bethany, and thank you, Futures Without Violence, Anna and Elena, for inviting me to participate with your national work. I really appreciate being able to elevate the ground level patient to the national level. So let's start with a patient of mine, patient OT. OT was a refugee woman in her first pregnancy. G1 stands for her first pregnancy. She hadn't had a child yet, so P0, that's our medical terminology. She came in and to see me. She worked at a local restaurant, and she came in because she had really bad morning sickness. She couldn't hold down any fluids. She was throwing up. She required intravenous fluids almost 2 or 3 times a week because she was getting super dehydrated and very, very dizzy. Due to her illness, she asked for a dispensation for a work note, a sick note for her work. So I wrote that for her because she couldn't work, she felt too dizzy, and she could barely, stand up and walk. After she gave the work excuse note to her employer, she came back the next week stating that she was really upset and she was really scared because her boss fired her for being unable to work and carry out her duties. I'm not a lawyer, but I do know that pregnancy is a protected class, and you shouldn't be able to be fired for pregnancy-related illnesses, and that those are protected under employment law. So I wrote her another note saying, excuse me, Mr. Employer, this is not a legal action, and she should be able to keep her job. She took that note back to her employer, came back the next week, very, very distraught. A lot more distraught, crying, and said that her employer is now very angry about the second note, and she is now threatened to fire her patient, her husband, her brother-in-law, and all the refugee employees from the same refugee group who worked at that restaurant. I didn't know what to do, and I do all this work in human trafficking. So how should or would I respond? Well, what I did in this case was refer her to our case manager, who then referred her to our medical legal partners in the community. Turns out that this patient was undergoing a lot of wage and labor violations, and her case got settled. And many years later, just this past December, this particular restaurant group was fined for a lot of wage and labor violations, and has settled all of those with many other employees at the restaurant. So is this an individual case of human trafficking for a patient who encountered the health center? So we're going to get into that a little bit more in our session. Elena? Next.
Yeah, so, yep. So I think, Kim, I love this quote from some of my colleagues that they developed here at Futures. Success is measured by our efforts to reduce isolation and improve options for safety, which I'm thinking about, especially listening to Dr. Chang talk about her experience with that particular patient. Our job is not necessarily to tell somebody what they should and should not do, but to let them know that they're not alone, that there's people, including advocates, legal services staff, other healthcare providers who care about their well-being and health, and that there's options for safety available to them, options for legal services available to them in their community. And it's through that lens and with that North Star in mind that we'll share the information and resources in today's presentation with all of you. Next slide. So maybe some of you might be familiar with CUES. It's an evidence-based intervention for intimate partner violence that's been developed over the years by my colleagues here at Futures. And you may have seen some of our multilingual safety cards, tools that are part of this intervention that we'll talk about today. CUES is Futures' universal education approach for healthcare staff to talk about health, domestic violence, and exploitation, and partner with domestic violence advocates to support patients and clients when they do disclose. So we'll describe the CUES intervention and some of the tools that Futures has developed related to this approach. This is just an overview in today's webinar. We have a lot more information and resources on our website about CUES and the educational safety cards that we'll mention today. My colleague Anna is going to be dropping some of those tools in the chat as we go along. And while this intervention is specifically for healthcare professionals and their partners, such as domestic violence advocates, I still think the information is helpful for legal services partners as well to hear and think about how it might apply to the work that your partners are doing in healthcare centers. So CUES stands for confidentiality, universal education, empowerment, and support. Next slide. So why might the patient or a client choose not to disclose to a healthcare provider that they have experienced or are experiencing intimate partner violence or exploitation? I mean, there's a lot of reasons, really valid reasons why someone might not disclose. Judgment and stigma around intimate partner violence and exploitation, fear of systems involvement, immigration enforcement, child welfare, or police involvement, fear of losing their job, which I think is particularly relevant thinking about the example at the top of the webinar, not knowing what might happen with that information, or somebody is controlling or exploiting them, fear that that person might find out that they told their healthcare provider, and a lack of awareness of their rights. These are just some of the reasons why someone might choose not to disclose that experience. Next slide. So CUES was really born out of this question. What if the disclosure or identification was no longer the goal for healthcare providers around when we support survivors in healthcare settings? Healthcare providers can be critical sources of information about health and services for individuals who have experienced domestic violence. We know that when a person talks to their healthcare provider about intimate partner violence, can receive really critical information about services, like Dr. Chang mentioned, and healthcare or other interventions that might help them exit a harmful situation. And at the same time, programs have reported over the years that the use of screening questions in healthcare settings, such as, are you feeling safe in your relationship? Have you ever been hit by your current or former intimate partner? Have elicited low disclosure rates in relationship to the prevalence that we know how common domestic violence is across all communities. And in addition, if the patient answers no and does not disclose whether they're experiencing domestic violence, we're missing an opportunity to provide support, to provide information about community resources that might help that individual or might help other folks in their family or friends. We're missing an opportunity to think about prevention. Next slide. So unlike traditional screening methods, CUES does not rely on a disclosure of abuse in order to provide a patient with information and resources that they may need. By using CUES, the provider can ensure that patients are aware of available survivor support services and have that information to pass along to friends and family who need it. This approach really relies on fostering strong partnerships between healthcare providers and domestic violence agencies. So the CE stands for confidentiality. It's really critical in this approach to know your state's reporting requirements and share any limits of confidentiality with your patients, and to ensure that when these conversations are brought up, that they're brought up in situations where we're seeing patients alone. The U and E stand for universal education and empowerment. Futures has developed safety cards that you saw in one of the previous slides and that we'll talk a lot more about, that provide information about healthy relationships and resources available to people who are experiencing domestic violence to help start that conversation between a healthcare provider and the patient. On the slide, you'll see some sample language that my colleagues have developed for how to normalize providing these safety cards that have information about support to patients. This is just an example. I've started giving 2 of these slides to all my patients, says the quote on the slide, in case it's ever an issue for you, because relationships can change, and also for you to have the info so you can help a friend or a family member if this is an issue for them. The card talks about healthy and safe relationships, ones that aren't, and how they can affect your health. It provides tips so that you don't feel alone. And then the S in Q stands for support. On the back of the card, there's text and hotlines for domestic violence services. And this is where those partnerships with community-based programs are so critical and important, so that if someone does disclose their experience and request services or support for their experience of domestic violence and abuse, the provider can then help that client contact relevant resources for violence support related or a warm referral to a local domestic violence program or victim service agency. And again, like I mentioned before, if you'd like more information about Qs, we have other webinars. We have one PDF in particular that goes into more detail around the Qs approach. And we also have we have so many safety cards that I'll talk about at the end. I think Anna is going to drop two in particular into the chat, a safety card on for adolescents in particular, and one a safety card on elder abuse as well.
Thanks, Elena. And you can find those in the handout section of the dashboard.
Kim?
Great. So we use a public health definition in our work with patients who are survivors. We recognize that the impact of emotional abuse and other behaviors or experiences affect us in our health, but may not necessarily trigger a legal or a criminal justice response. So what is intimate partner violence? It is a pattern of methods and behaviors to gain power and control over and or hurt an intimate partner. And so when we look at this public health definition, you have to understand that the legal definitions are often more narrowly defined with particular focuses on physical and sexual assault. And the public health definitions, because they're broader and because they cover this whole range of controlling behaviors that impact health, it includes things like emotional abuse, social isolation, stalking, intimidation, and threat. And so in healthcare, in our work together with medical legal partnerships and with domestic violence programs and human trafficking programs, we have an ability to help a broader range of people who are experiencing all of these types of behaviors and experiences, which might not fit into the legal definitions of domestic violence. Next slide, please. The same thing goes for human trafficking. Now, this is the federal human trafficking definition. It's in federal legislation of the Trafficking and Violence Protection Act of 2000. I'm going to bring this up because we do have a legal audience here, and I'm going to show you next how we go broader in healthcare. So whether a person's experiences fall under this legal definition of human trafficking or not, we might never know. Just like my patient that I talked about earlier, OT. We still want to be able to offer support to whoever is wanting education and to help prevent human trafficking. So this federal definition is sex trafficking. Sex trafficking is the recruitment, harboring, transportation, provision, obtaining, patronizing, or soliciting of a person for the purposes of a commercial sex act, in which the sex act is induced by force, fraud, or coercion. Or it's a commercial sex act in which the person is not yet 18 years old, okay? So anyone under the age of 18 in a commercial sex act is considered a victim of human trafficking. And it is also labor trafficking. Labor trafficking is the recruitment, harboring, transportation, provision, or obtaining of a person for labor or services through force, fraud, or coercion for specific purposes of involuntary servitude, peonage, debt bondage, or slavery. And so that's the legal definitions in federal legislation. State legislation may also have more specifics in them, but this is the legal federal definition. Next slide, please. All right, so in terms of sex exploitation and labor exploitation, we go a little bit broader, and we go broader in healthcare because, like Elena spoke about, we want to encompass the whole range of experiences that might affect a person's health, whether or not it meets the legal definition. Also, this year in the UDS measures for health centers, they are measuring intimate partner violence and human trafficking through proxy measures of ICD-10 codes of sexual exploitation or labor exploitation. So they're using the terms exploitation. So exploitation, sexual exploitation is also a broad term, which includes transactional sex, solicitation of transactional sex, and exploitative relationships. In terms of labor exploitation, that's a much broader term. It's not a legal term, it's where an employer unfairly benefits from an employee's work. Labor violations, like the one my patient OT experiences, is a legal term, and it's used when employers violate federal, state, or municipal laws related to worker treatment, workplace safety, or record-keeping requirements. Now, when you look at this diagram, you can see that people who are experiencing labor exploitation can also have health manifestations because of that exploitation. And so that's what we're trying to get at, a broader definition so that we can help our clients and our patients. Next, please. Elena?
So going back to what we talked about earlier about our definition of success, that the goal is to improve options for safety and to reduce isolation. And like Dr. Chang mentioned, and we talked about, there's many reasons why a person may or may not identify with terms such as victim or victimization, exploitation, and trafficking. And how they think about that experience may also change over time. And health responses, we know, are strengthened through our partnerships with domestic violence advocates, legal aid, social services programs that provide comprehensive care to patients to meet them where they're at and wherever their experiences may fall on a continuum from exploitation to trafficking. Next slide.
Okay, look, this is a list of from some research studies about the health impacts of intimate partner violence and human trafficking. It's not exhaustive. And I'm not going to sit here and tell you this is what you need to look for in your patients, because we know that there are many long-lasting health consequences for intimate partner violence and human trafficking, in addition to immediate injuries and bruises and physical injuries. The health consequences can persist even after an abusive relationship or trafficking situation has ended. This is what the research shows, but really there's probably a whole number of health conditions associated with violence, abuse, and trauma. And so, next slide, please. We also think about our mental health manifestations of violence, abuse, and trauma. You know, I think in this time of COVID and in this time of a lot of mass violence, there can be a lot of triggers for post-traumatic stress disorders, anxiety, depression, sleep disturbances, emotional detachment. I think our society and our community has experienced a lot of this collectively over the past year. And when you think about that in patients who have directly experienced a lot of violence, abuse, and trauma, you know, a lot of these manifestations can occur years later. I do have patients who have experienced something many years ago, and things recur depending on what's going on in the news cycle or what's going on in current events. And so, you know, we have to remember that just because somebody might not have an immediate injury or bruise, that manifestations of intimate partner violence and human trafficking or exploitation can persist long after the experience has ended. Next slide, please.
Okay, Elena and Dr. Chang. We're going to take a moment and be joined by Anna and April to ask the audience to pause. There's a question on the screen, and we're going to ask you all to use the chat box, and then Anna is going to read out some of those responses. So how is intimate partner violence and human trafficking showing up for clients or patients during the COVID-19 pandemic in your communities? Take a moment, share just some brief remarks, and we'll try to read a couple of them out.
And I know there are many advocates who are joining us from community-based programs, whether domestic violence programs or human trafficking. We would also love your insights in terms of how COVID has changed perhaps some of the dynamics and the ways that you've shifted around your clients' experiences now during COVID-19. So I'll look for those answers in the chat. One person mentioned in schools they're seeing into people's homes and seeing what's going on more with red flags. So definitely we've heard a lot incidents playing out over the screen, and certainly even with telehealth or other virtual visits, you might not always know who else is around as you're supporting your patients or clients. And so we're going to offer some ways to do that in a safer way in terms of the universal education. So we'll talk more about that. I also see someone said less contact with the outside world means less opportunity to provide options for them to leave. So increased isolation, fewer, support, a smaller support system around you in terms of, who you're interacting with day to day is much more limited. Increased sense of helplessness, much harder to get assistance due to limited court, due to closures and limited court availability. We've seen a lot of changes with the courts, just in terms of what cases, how cases are being handled, and some delays there. Someone who's a forensic nurse noted that their advocates are only available by phone and are not coming to the hospital, even though the hospital has lifted restrictions. So some barriers in terms of programs where maybe you were used to, through your partnership, that having advocates come directly to your health center, to your hospital to provide that follow-up care, and now having to rely more virtually on phones or telehealth. Also seen here, again, isolation and increased alcohol use and suicidal adolescents in the emergency room. And this really touches on what Dr. Chang was just talking about in terms of some of the behavioral health impact. And we're definitely hearing more about that suicide ideation and risk increasing. Also seeing greater basic needs such as food. And I think that's a really important point and touches on some of the, sometimes the survival strategies of people trading for sex or needing a safe place to sleep that night or shower, and food, just meeting your basic needs in that way. I'm just looking at a few more. One person said their health center in Alaska has been requesting of us at the Primary Care Association that we provide domestic violence, human trafficking training. So they are seeing an increased need in the clinics to respond. So a growing awareness for sure, and different health systems wanting, more support and education. And I love that they're reaching out to you to provide that support and to solidify that partnership in terms of the person who typed this in. So I think I'll turn it over there, but just a lot of important comments, and we're going to follow up here and share some of the results as we've heard them also from the National Hotline on Domestic Violence that did a study just on this topic around how COVID-19 is really affecting survivors right now.
Great, thanks, Anna.
So as Anna mentioned, the National Domestic Violence Hotline collected data from March 2020 to May 2020 that really demonstrated this increase in call volume during the pandemic. I think something that a lot of folks that are working in community-based programs and domestic violence centers were feeling. And they did see an overall increase in the total number of contacts that the hotline received. And this graphic kind of shares a little bit more about how some of those contacts came in to the hotline and where those increases landed. Next slide. These are some of the things that survivors shared that the hotline noted. A caller was experiencing escalation of abuse. They had tested positive for COVID, and the abuser was using isolation to keep them from contacting their family. The abuser threatened the survivor with deportation. Caller said that they could not file paperwork to remove the abuser from their home because the court was closed due to COVID, something that was mentioned in the comments just a minute ago. I mean, real barriers and obstacles that folks were experiencing during a time that was increasingly challenging. And I think that we share this to sort of, share what the reality has been on the ground, and also to share why, leveraging resources, thinking about creative partnerships has become so important and critical during this time. Next slide. So really quickly, because this is a mixed audience, I think, of folks working in different sectors, I do think it's important to just speak briefly about what are the types of things that the domestic violence program in your area may be doing. Domestic violence and sexual violence programs provide so many critical services to survivors: safety planning hotlines, crisis support, connecting survivors to appropriate legal services, support groups, counseling. And one thing I just want to note that certainly this changes depending on the program, and so it's so important to have really honest conversations with your partners about the services that they provide. And then to just share that, domestic violence programs are providing crisis support, absolutely, but many are also thinking long-term and developing programs around leadership, around long-term supports that build resiliency as well. Next slide. And what's important information for domestic violence advocates about health? Well, we know that domestic violence advocates are in this unique position to intervene and reduce health consequences, some of which Dr. Chang mentioned earlier. And many survivors have not received health care in a long time and are maybe primarily concerned about their children's health. And we know that taking care of your own health as well is an important part of healing as well. Domestic violence advocates are focusing on the whole person, and like I said before, not just crisis and experiences of violence. And in this time during COVID, health centers and public health can help get advocates and clients COVID testing, health education, vaccines, really critical responses to the pandemic. Next slide.
Okay, for the mixed audience as well, I'm going to share a little bit background of the community health centers. Community health centers are community-based and patient-directed organizations that deliver no-cost or low-cost comprehensive primary care. They're located in every single state, every single territory, in DC. We have services particularly for primary care, pharmacy, integrated behavioral health, substance use disorder programs, dental, oral health services. And what's really important is that Bethany mentioned earlier when she was talking about medical legal partnerships, and that civil legal services is an enabling service. Community health centers provide things like enabling services. So what are those? Those are services that enable a patient to access healthcare, to see me, to see a doctor, to see a nurse, to see a behavioral health specialist, a therapist, to see a dentist. These kinds of enabling services are things like civil legal aid, transportation, interpretation, case management services, enrollment and eligibility counseling for insurance. And these are things that are really crucial and key for our patients. Health education, these are really crucial and key for our patients who are by federal statute required to be in medically underserved areas or a medically underserved population. Next slide, please. And for people who are very vulnerable and marginalized, we as healthcare providers can be oftentimes lifelines. We can be first responders for those experiencing intimate partner violence or human trafficking. Sometimes we're the only person a patient is allowed to speak to. Sometimes it's the only kind words your patient has heard. Sometimes we're the only access to information on resources, health, and safety. And as you've seen during this year of COVID, we're a trusted resource about COVID-19, giving vaccines, giving testing sites, and vaccine eligibility. And so, hopefully there can be some partnerships where those advocates who are not yet allowed into the hospital or who are not going to hospital can become vaccine eligible as healthcare workers who are going and helping our patients. So we're hoping those kinds of partnerships can broaden so that we can take care of our advocates who are helping our patients as well. Next slide, please. In terms of legal services, you heard some of the things that Bethany mentioned earlier. So for domestic violence, survivors need a lot of legal services for housing, for if they're being evicted or if they don't have protections because the abuser is holding onto the lease or the mortgage, family law for temporary restraining orders or permanent restraining orders, child support, spousal support, orders of protection, immigration-related legal assistance. Very, very important for the kinds of patients that I see at my health center. Public benefits, criminal record expungement. Same thing, next slide, please. For human trafficking, they're very similar. You can click forward. For human trafficking or those who are exploited, they're in very precarious situations, and civil legal aid is a way of preventing exploitative situations from becoming worse and having worse violence, abuse, and trauma. So very, very similar kinds of legal issues that medical legal partnerships, and domestic violence, human trafficking violence advocates can help with. Next slide, please. In addition to the civil legal aid, these are some of the other services that we hope the medical legal partnerships can help connect our patients for exploitation and human trafficking to immigration services and criminal justice legal aid. Next slide, please.
So, at the heart of what we've been talking about today, and the heart of this approach today is partnerships. And this graphic really speaks to partnerships between domestic violence programs and community health centers. But I think the principle that partnerships can support survivor health and promote safety in a coordinated way also applies to the partnerships with medical legal partnerships as well. And actually, my colleague Anna and Dr. Chang and Hamida Yousafzai have also authored an article specifically on this topic about coordinating, partnering healthcare with medical legal partnerships and domestic violence programs that you can check out, and that we've included in the handouts. And in addition to offering warm referrals to support survivors, programs, as we mentioned, can be cross-training their staff on issues such as healthcare enrollment. It's open enrollment time, so that's a particularly important topic. Public benefit supports that are available to survivors, trauma-informed care. And during COVID, these types of partnerships can be also coordinating outreach on COVID vaccine eligibility, in particular for harder to reach communities, helping survivors get healthcare more efficiently when they're sick. And these partnerships might look different depending on your community. And Futures has developed some tools on our website, such as sample MOUs and things to consider when formalizing these partnerships. One of those tools, Building Fruitful Partnerships, as a handout that's also included in the handout section. And one thing I don't want to get lost is that, it's so often true that these partnerships are built also on the strength of our relationships with each other. And that, yes, it's important, it's critical. We got to get down to the nitty gritty and talk about the services that our partners provide, eligibility requirements such as income requirements or geographic limitations for the services or programs that might be located in some of these organizations. And doing that, I think, can really improve the quality of that referral and ultimately improve a survivor's experience in all of these programs. But it's also true that we can't forget to create a space to connect with each other and get to know each other as well, that's also part of partnership building. And some of the ways that we can do that is to have conversations and ask questions like, why are we doing this? What are our goals in developing this partnership? And how did you end up doing the work that you're doing here? And what has kept you motivated to work through the challenges that we've experienced during this last year? What do we want to build together? What do we want to tackle together? This connection between people, thinking about a different future, it's part of what we talk about a lot and work with domestic violence survivors. These are perspectives that we bring to our work with people who have experienced violence, but they also apply to the work that we do in building connection with each other and strengthening the quality of our partnerships across programs. Next slide. So really quickly, you can go to the next one. I just want to share Futures, and I know the National Center for Medical Legal Partnership as well has a bunch of tools that we just want to highlight as we sort of close up our presentation. One, the tools that we described and lifted up today are available through our website at ipvhealthpartners.org. You can also email our staff as well if you have other questions. Next slide. We also, I mentioned earlier, the safety cards that are part of the CUES intervention. We have so many safety cards, y'all. Populations and setting specific safety cards on adolescent health, American Indian, Alaska's Native and Hawaiian communities, college campus, so many others. Many are available in English and Spanish, and there's the general safety card is available in other languages as well. They're available through our website where you can go and take a look at them. I know that Anna as well dropped a couple of them in the chat. Next slide. And I'll pass it over to you, Bethany.
Thanks, Elena. Yeah, so we're going to pause and take maybe, Anna, if we could highlight 2 to 3 questions, and then we will then transition to truly closing out by also plugging shamelessly some additional learning opportunities that we have coming up, where you can also get to connect with peers to emphasize Elena's point. Anna, do we have a couple of questions we can bring to the top? And then I should note, I forgot to note that for folks, I know we're limited on time and we can only get to a few questions now, but we do take those questions that came in and often follow up via email to try to get some answers to folks. So I'm sorry, Anna, please go right ahead.
Yeah, no, one person was noting that they had some difficulty calling the National Domestic Violence Hotline and wasn't able to get through with a counselor there. And I think, you know, with COVID, I know that they have really received an increase in volume in terms of calls and texts. One thing I would offer is that every state and territory has a coalition, a state coalition or territory coalition on domestic violence that works with member programs all across their state. And they're another great resource in terms of identifying your local programs, because really the goal here is to always have 2 referrals. One, the national referral to national hotlines and resources, and then to offer your patients or clients something more local right there in their community, what's available, or in the neighboring community if they feel more comfortable going just outside. And so take a look at the QA, it should be visible. I popped in the URL for the National Coalition Against Domestic Violence, and then tag their state coalition page so you can identify your state coalition and connect with them to then drill down to a local program. And know that it's been mentioned a few times, but ipvhealthpartners.org has some sample tools just in terms of establishing that partnership and using an MOU as a tool to formalize that. And I'm also looking at the QA here. There were some additional comments from folks just about some of the challenges right now during COVID-19. And one person pointed out that they've been using text more to communicate with clients remotely, especially as it's harder for survivors maybe to talk on the phone because of people around them. That texting is a safer modality right now for many. And so they've shifted more to text, which is great to see. And I'm just gonna scan here some other questions.
Anna, just really quick, I know you mentioned earlier telehealth, and I just wanted to also lift up, there are some resources as well at IPV Health Partners about telehealth and adapting some of the tools that were mentioned for that particular
Thank you, Elena. And you know, when you visit IPV Health Partners, look up to the top. You'll see a banner right there on the top of the website with COVID-19 information. And if you click there, you'll access some of the specific tools we've developed, as Elena said, just for telehealth practices, and really thinking differently about confidentiality and privacy, because it looks so different with all of us in our homes right now. So check those out. I also see a question here. What do you suggest we tell clients who are afraid of police involvement and or immigration status? And those are really valid concerns. People have a lot of concerns about systems involvement more generally, and for good reason too. And sometimes, right, based on people's experiences. And so really the most important connection for clients and patients experiencing trauma, violence, and abuse is with a community-based domestic violence advocate or human trafficking advocate, if your community has a human trafficking program as well. Some don't. For some communities, a domestic violence program really is the go-to for a range of survivors, including trafficking survivors. So working with an advocate who has confidentiality and can also help connect folks to a community health center that don't ask about immigration status, you know, that is a huge lifeline just in terms of addressing any health needs they have. But for some survivors, they may not want that criminal involvement in terms of working with the police, but there's a number of other options, supportive options and resources that advocates can help leverage, and also through the medical legal partners can also support them with other legal needs that may not in fact be criminal needs. And I would just hand it over to my colleagues if they wanted to add any additional points just on that and reducing some of those barriers.
I will quickly note that the National Center, folks may be wondering, we've highlighted an MOU for a particular type of partnership, and I would say that there are exact parallels that you can help to look at both side by side and integrate in the medical legal partnership context. The National Center also has some sample MOUs. I've seen what IPV Health Partners has shared, and I do think there are ways that MLPs around the country are already integrating both aspects. Same thing for privacy and consent concerns, to be able to share information among partners. There are certainly parallels, and there are MLPs partnering with DV partners that we can help to pull from the field and share. Before we break into sharing what's coming up next, I just want to make sure, Dr. Chang, Elena, would you like to share any closing remarks? And thank you, Anna.
I would. I think as a physician in a community health center who has worked with patients experiencing human trafficking and intimate partner violence, I think the need for these partnerships is so great and needed, and the fact that lawyers are willing and able to step up and help really makes the work a lot easier to hold, because a lot of the things patients present in a medical setting, but their issues are solved outside of it with you folks. So I really want to express a lot of appreciation for the advocates who provide those supportive connections and help for the patients, as well as the lawyers on the ground listening, because we rely on you and you help our patients tremendously in terms of their health. You probably can't see it because you're not in the clinic setting, but I see it. So thank you.
Yeah, and just to say, I'm just really grateful to be here. I've worked, aside from Futures in my past life, I've worked with community-based organizations, and I know that it can be, when the work is voluminous and you're moving as quickly as you can. I think sometimes thinking about things like developing partnerships and taking time to do this can be difficult. And I'm just hopeful that some of the tools that have been lifted up by the National Center for Medical Legal Partnership and with the NHN can be helpful in helping you all think about ways to better create networks in your community to support folks.
On that note, we are not going to leave you all with just this one webinar. We do have more coming up, right? We're not leaving you hanging with just this content. So first, our friends at Friends Without Violence are partnering, or the National Health Network on IPV and Human Trafficking are partnering with other NTAPs, the National Healthcare for the Homeless Council and National Center for Equitable Care for Elders. I strongly, at the National Center for Medical Legal Partnership, want to encourage everyone to sign up for the learning collaboratives that our partners and we are pulling together and putting out there. That way we can connect with each other as peers and learn from each other. So coming up on May 21st, you'll see that they're supporting providers and centering survivors. And then, you have to apply by May 21st. And then for the second learning collaborative on aging with respect, you have to apply by April 16th. My guess is if you apply later, you probably will still get in, but I am also saying apply by those deadlines because it matters. And then for the National Center, we hope you'll join us on April 6th. We were actually able to somehow pull together another amazing group of experts from the field. Rebecca Sanderford, Keegan Warren Clem, and James Tufel will help us talk about how to move upstream from patients to policy to really be able to address more than individuals, but do that population health work that we talked about earlier in today's webinar.